All right. Well, I am like starstruck a little bit here. Like I've got two folks who are well known for their provocative approach to multiple myeloma, and I hear you disagree on everything the other person does. So I'm glad you're able to join me.
I'm usually right, though.
Absolutely, absolutely.
Just to be clear.
It's the accent. I think the accent just gives a little bit more of an authority to it.
Instant credibility.
Yeah,
Just older. That's the key.
that too, and wiser.
Older, wiser.
And
Yeah.
wiser. But Dr. Lonial is with us and Dr. Stewart with us. I think you both are beyond introduction, but just there's maybe a couple of people who just don't know you. For these two people, maybe where you are, Keith, right now, and what you're doing.
I'm Keith Stewart. I'm at Princess Margaret Cancer Centre in Toronto.
I'm Sagar Lonial. I'm at Emory University in Atlanta.
So it's a big ASH for myeloma, it seems like. You guys made it to the plenary session, so which, by the way, we are taping for context. We're taping about an hour or two before the plenary session. I feel like it's before the Super Bowl. What's being presented in myeloma at the plenary session?
Well, what they're presenting is a 4-drug regimen, which is building on the backbone of VRD or Proteasome, lenalidomide, dexamethasone, adding an anti-CD38 antibody. In this case, it's ixazomib. We'll also hear at this meeting about a similar trial using a different anti-CD38 daratumumab. So it's a phase 3 randomized trial, standard of care versus the 4 drugs. And I think the conclusion is 4 drugs are better. But
So it is 4, so it's DARA, it's VRD plus IXA.
So the plenary is KRD plus IXA
Okay.
versus
got it wrong.
versus
KRD.
KRD plus ISA versus KRD
Okay. And
with transplant, consolidation, and maintenance, and it's sort of a parallel.
See, I already got it wrong. So it's good that you're here.
Yeah, I don't know. I'm still going to believe you. But my question is, what's the maintenance arm? What is so? It's maintenance versus not, or everybody gets maintenance?
Everybody gets maintenance, but there's a randomization between ISA-LEN versus LEN.
Okay. So Keith, I mean, a lot of folks who are viewing this, they get a little bit. They're not certain. Is there a particular proteasome inhibitor that you think is really better? I mean, should you use K versus V, or it doesn't matter?
That's a great question. So the issue. So yesterday there were multiple abstracts using carfilzomib, Smoldering, Frontline, and it's extremely good, and it looked very good in all those indications. The problem is there's no regulatory approval for the drug anywhere in the world in frontline setting. So it's great we're doing all these trials, but there's actually no way to use the drug except in the United States where people can get away with it. But it sort of feels a little bit futile to be doing all these studies without an endpoint. So Mary V. Mateus suggested yesterday put all of these studies together, often more institutional or cooperative group studies, and maybe we can submit that regulatory package to try and get approval to use the drug around the world. Less neuropathy, better PFS overall.
I mean, was there ever a randomized study comparing KRD to VRD?
Yes, there was.
Tell us about that.
The ECOG trial did KRD versus VRD with no transplant. And again, it was only standard risk patients. The high risk patients were excluded. And in that randomized trial, PFS was identical between the two. So while there's a lot of data suggesting KRD may be better, the head-to-head trial has not been done with a transplant that shows that
So
data.
why can't you guys do KRD, VRD in high risk?
Nobody's done the trial yet. It should be done. It would be an important trial. I think the assumption is K will be better, but as Sagar just said, it hasn't proven better to Proteasome in other studies so far. So there is also a convenience issue, I think, to consider. Carfilzomib is still given intravenously once a week. Proteasome is subcutaneous injections, pretty well tolerated except for neuropathy. So it's going to be hard, and it's generic in a lot of places now, so it's going to be a bit hard to dislodge that.
So do you think like the use of K in the plenary abstract or data is going to take away from the general outcome?
I think the main message here that is going to be the addition of isatuximab is additive, and I think people will extrapolate from that for Proteasome, but they may have the same registration issues. I mean, they're trying to get registration for carfilzomib as a partner, which isn't available.
Well, but I think we did also hear the IMROSE study in a transplant ineligible patient population, which was ISA VRD versus VRD, is also positive. We know that from a press release that came out just this week. So I think ISA will find its way to an indication up front with either probably VRD. I think that'll be
it's
easy.
also intravenous for the time being.
What's unique about ISA?
Well, I think actually they're very equivalent drugs. The difference right now is in subcutaneous versus intravenous delivery. So daratumumab subcutaneous. ESA is still intravenous, but they are doing head-to-head trials now to show that subcutaneous is just as good. But it'll be a year or two till we get the results, I suspect.
But in essence, like, is there, I guess what I'm trying to get at, let's say that we take the KRD plenary session, would it have mattered if I put DARA versus ESA? Do you think there's a difference in the way these
My
drugs
personal
work?
opinion is no, but I don't know if you disagree.
They work similarly, just a matter of...
You're actually agreeing with me? This is good.
Well, you agreed with me.
We're making
We have
progress.
an agreement. I want to apologize. They agree with each other, folks, but I'll promise you the next one they won't. So there's another trial you were mentioning before we went on the air. There's a mnemonic to it. What was it?
Perseus?
Perseus.
Perseus. Perseus is a late-breaking abstract at this meeting. It's a large randomized phase 3 trial with DARA VRD transplant, then consolidation, and then DARA-LEN maintenance versus VRD transplant, consolidation, and LEN maintenance. So it's DARA in the top arm, no DARA in the bottom arm.
Okay.
And that data looks very good. I think it is basically taking the Griffin trial, which was a small phase 2, and confirming those results in a larger phase 3.
So 4 better than 3, is that what we're saying?
Sure.
Yeah.
Even in maintenance, 2 better than 1? See, I'm still not convinced. You guys have proven to me that I should add something to lenalidomide maintenance.
This is one of the controversial things about the study is there is an assumption that daratumumab is helping, and whether you can get this approved as a package, a single line of therapy from 4 lines, transplant, consolidation, and maintenance with both drugs, whether the regulators will allow that to go through, and that will allow us to access DARA. But you're right, there's no randomized trial that proves the point.
And I think your skepticism is appropriate in the sense that if you look at RVD 1000,
Which is your
our
Emory's
data set,
experience.
1,000
Nobody
patients.
else knows that. Sagar.
It's 1,000 patients treated consecutively over an 8 to 10 year period with 10-year follow-up. So if you look at that data, RVD, single transplant, and then lenalidomide maintenance until progression, the median PFS in that group is 80 months. So you got to be pretty good to beat 80 months. And when you bring DARA RVD up front, we present that at this meeting tomorrow, in 300 patients, comparing it to that 1,000 patient series, the PFS is already better with the addition of DARA up front.
Yeah. I mean, the thing is, the reason I mentioned maintenance, at least in my simple brain, is that I always view that if you're doing maintenance, these are patients who are in CR, like they're, technically you're maintaining someone who, so I worry about over-treatment in someone who is complete. It's different when you're treating a PR or somebody, that's where I always get particular on the maintenance.
The company does a randomized trial of DARA-R versus R alone, but it's only in high-risk, MRD positive or high-risk patients.
So the SWOG study is looking at that, and there's a second randomization. If you're MRD negative, you can stop one of the drugs. But yeah.
So my last issue, before I let you go, you have a boxing match later on, I know, I heard.
Yes.
But there's probably nothing that gets more attention on social media, X formerly known as Twitter, than smoldering multiple myeloma.
Yes, with good reason.
For a good reason. So the school of thought is that there should never be a reason to treat smoldering myeloma. Which school of thought are you in?
I don't treat my smoldering myeloma patients. Generally, I still tend to watch them. I mean,
Even the high risk?
My colleague here, well, including high risk, my colleague here is a fan of lenalidomide. I don't know if you use that in practice or not. Do you?
So we have 2 clinical trials in that setting. So we have options for people either way. So we don't treat many off study. If they want to go on study, certainly the ECOG trial of DARA Lendex versus Lendex is one option. And then we have a trial of iberdomide versus...
There have been some very aggressive attempts to get rid of myeloma, smoldering myeloma, including KRD and transplant by the Spanish group.
Correct.
And what, to me, I took away was it wasn't curing most people. Well, they have a number of very good long-term survivors. And people are going to live, even if they need treatment in the next 2 to 3 years,
right.
they're going to live 10, 15 years. And the worst thing you can do is cause toxicity and even perhaps death in those people. So yesterday we saw a very brave trial to use teclistamab, anti-BCMA bispecific antibody in high-risk smoldering myeloma with spectacular responses, 100% molecular CR in about 9 or 10 patients with short follow-up. But the concern is that those drugs we now know for sure put people at very high risk for infection. And how many, what's your threshold for what is an acceptable risk.
Especially in smoldering.
Yeah,
correct.
people are going to live 10 years anyway.
I think conceptually, and again, I'm not a myeloma expert here, but conceptually, I have no issues treating patients with smoldering on clinical trials. But I kind of feel the control should be nothing.
Yeah.
Like if
But
you're
we've
going to
done
really
that twice. We have two
Tell us about
randomized.
that.
We've done two randomized trials with either Len or Lendex versus observation, 400
Was there
patients
overall
in aggregate.
survival advantage?
In the Spanish, yes, but overall survival is not the right endpoint.
Why not?
Because the median survival of a myeloma patient is between 10 and 15 years.
So you just cause
why do you
toxicity for people that don't
no,
live any longer? No,
if you can change when a patient develops myeloma or prevent them from developing myeloma, that's the endpoint. If
this is lead time bias, though, right? Yeah.
if you give intensive therapy, absolutely.
And in the Spanish trial, by the way, half of them had myeloma anyway. They just didn't.
Well, we don't
count
know
as myeloma
that.
those
We don't
days.
know that. It's probably more like
look,
10%.
but in fairness, if you have evidence here, disease-modifying drug.
Yes.
You know, stealing from the rheumatoid arthritis of the
Right.
world and stealing of autoimmune. If you have evidence that you're modifying the disease and changing the disease
Yeah.
as an entity, I can understand the attraction, I guess, of trying
Yeah.
to do this. But what you're contesting is we don't know if we're, like, it's net harm versus benefit,
Correct.
right?
I mean, so I'll give you the index case that I think supports, and it's an anecdote, no kidding. But the first patient we put on this trial was a high-risk smoldering patient 10 years ago that got put on lenalidomide and has not progressed.
One of the patients that went on the trial early when I was at Mayo Clinic died of a pulmonary embolism, so if you remember.
I
So
do.
This is my point. I actually think conceptually it's the right thing to do. Early treatment, early intervention, but it probably needs to be somewhat potentially curative and low toxicity.
But
That's the
you
issue.
have to really highly selective which smoldering. I mean, because there are many smoldering that will never require
That's
therapy.
right.
I mean, they will never require therapy. So you have to take patients who you think they absolutely need treatment
Right.
and say, if I treat a year before, this is going to make a difference. So I don't know.
I think it's coming. I think we will start treating it earlier and earlier. And as the drugs get less toxic and more effective, it will come. We're pretty close.
Yeah.
But for now, I'm still being conservative.
I have to say I'm disappointed. You guys agree a little bit more than disagree. I mean, because being from Ireland, as you know, they don't agree with a lot of things,
Yeah.
right? I mean,
Well, he says he's from Georgia, but look at him.
I mean, yeah, he's Georgian. Well, folks, thank you so much for joining me on the HemOnc Pulse, the infamous, the renowned Dr. Stewart and Lonial, coming to you from ASH 2023.